Okay, we're on.
Alright, I'm going to talk to you guys today about the Australian healthcare system. Fun fact, Australia is considered an island because it's surrounded by water. But in fact, it's made up of more than 8,000 islands, and actually it's an island that is a natural quarantine zone. So this is Australia. Just a few things that you might need to know. This is the population. Most of it is surrounded around here, zooming over here, but as you can see, there's not much in most of Australia. Like we mentioned, Professor Schuster mentioned yesterday about the fact that it's a huge country, It's a continent, country, all of it, and an island, it's all. But most of the population is located in about 20 to 30% of the land. So the population is over 24 million. The main religion is Christianity, a couple of others, and here you have the age pyramid, which looks a lot like the tower in downtown Haifa. So the government, it's one of the first countries to establish democracy in the modern world. In the mid-19th century, they set about writing constitutions which produced democratically elected parliaments. There are 5 core defining values of democracy, which are freedom of election and being elected, freedom of assembly and political participation, freedom of speech, expression, and religious belief, rule of law, and then basic human rights. They follow the British Westminster tradition, where they have the Governor General, who exercises supreme executive power of the Commonwealth, the Prime Minister, who leads a cabinet of ministers, who is appointed by the Governor General. There are 560 local councils and Parliament, which makes laws, authorizes government to spend public money, scrutinizes government activities, and it's also a forum for debate on national issues. All Australians, citizens that are over the age of 18, must vote both federal and state elections. The economy in Australia is considered to be one of the strongest economies. In 2015, the growth was about 3.3%. It is also a leader in agricultural products, education, tourism, mining, and wealth management. A few numbers that you need to know. The GDP is 1.2 trillion. GDP per capita is about almost 50,000. The growth rate is 2.8. The out-of-pocket expenditure is 18.8, and the out-of-pocket expenditure is any direct outlay by households, including gratitudes and in-kind payments, to health practitioners and suppliers of pharmaceuticals, therapeutic appliances, and other goods and services whose primary intent is to contribute to the restoration of enhancement of the health status of individuals or the population groups. It is part of the private health expenditure. And then the health expenditure, which is part of GDP, is 9.4%, and then per capita is a little bit over 6,000. So some health demographics. The life expectancy in Australia is pretty high, as you can see here, it's highlighted in red. The men are 80, women 84, and the average is 82. As we all know, women tend to live a lot longer. Infant mortality is low compared to some of these other countries, 3.4 per 1,000. And then I just thought to put the deaths from cancer up. It was just very interesting. It's 192 per 100,000. And I found this interesting only because I remember when I was working in the cancer center in the States, there was a lot of talk about, skin cancer, and there was a lot of research on skin cancer in Australia and how high it was, but the fact that the deaths are not as high as some of the other countries I just thought it was pretty cool to look it up. Physicians, there's 3.3 per 1,000, and then you have 10.6 per 1,000 nurses and midwives. I'm sorry, Linda, but they put that together.
It's fine, because I'm glad that in my statistics that they left something in there.
There's about 4 hospital beds per 1,000. And just to show you a little bit about the proportion of health practitioners that are employed in the major cities, and like I showed you before, the major cities and the population is kind of towards the eastern side of Australia. You have a little bit on the west, but there's not much north, not much in the middle. And there's the Australian population that's in the major cities is about 70%, and that's pretty high. And so you have all these different health professionals that are employed in the major cities. So not a lot are working in the minor cities. And then so here's another map, and you can kind of see that it's pretty similar to the light map that I showed you, where the population is. Like the hospitals are mainly around the edge of where the population is condensed, and then you have a few hospitals inside Australia to the north, but not that much. So leading causes of deaths in Australia, the leading cause is coronary heart disease. More male die from coronary heart disease than female. And so the health system. Who uses the health system in Australia? Well, Australian citizens, overseas visitors, temporary and permanent visa holders, and asylum seekers. Types of healthcare. You have primary healthcare, which is the first point of contact, as always. It's provided outside the hospital system, and there's no referral that is needed for this level. The services that are provided are by general medical and dental practitioners. There's nurses, indigenous health workers, pharmacists, physiotherapists, dietitians, chiropractors. They're delivered at general practices, Aboriginal and community-controlled health services, community health centers and allied health services, also the public health promotion and prevention centers. The networks are the Medicare locals, which are plan and fund extra health services. They are created as local organizations, and they coordinate and deliver services to meet the local needs. Secondary health, medical care provided by a specialist or a facility upon referral by a primary care physician. So they go to their primary care and they get referred from them to their secondary care. Their services that are provided by hospital or specialist medical practices. Now the third is the hospital care, and usually you see it in other countries as tertiary care, but here it's hospital, and it's both private and public hospitals. The emergency department is actually extremely critical. It takes care for patients with urgent need for medical or surgical care for patients returning for further care, and patients waiting to be admitted. There's local hospital networks. There's about 136 of them. They improve delivery of care, coordination, access to health services. There's small groups of local hospitals or individual hospitals. They're linking services with the region through special networks across state or territories. They're responsible for hospital management, and it increases local autonomy and flexibility so that the services are more responsive to the locals' needs. Healthcare systems. Medicare. It's a little bit different than the Medicare provided in the States. Medicare provided in the States is for the elderly. Here it's provided for the population. It was introduced in 1984 to provide free or subsidized treatment by health professionals, free treatment for public patients to public hospitals, public, not private, payment of benefits or rebates for professional health services, subsidization of the cost of wide range of prescription medicines, and it may be covered by you can be covered by both Medicare and a public or private insurance if you are willing to pay the private insurance fees. The government did this because they want all to have access, so they do this by supplemented social welfare arrangements, smaller out-of-pocket costs, and more generous safety nets for those who receive certain income support payments. Medicare and hospital treatments, it is covered by, so your hospital treatment is covered by Medicare. It's free or subsidized treatment by health professionals. 75% of the Medicare schedule fee for services and procedures if you are a private patient in public or private hospital. Some healthcare services in certain countries are also under the Medicare insurance. Public patient cannot choose their own doctor. So you, as a public patient, have to be given the doctor that you're given, and you're just going to have to go with it. It does not cover a few things like medical and hospital services, which are not medically necessary, or surgery solely for cosmetic reasons, and also ambulance services. Medicare and medical services. So when you're visiting a doctor outside a hospital, Medicare reimburses 100% of the fee for a general practitioner. 85% is reimbursed for a specialist. If a doctor bills Medicare directly, the patient will not have to pay anything. If charged more than the fee, then the patient has to pay the difference. Medicare, though, does not cover the following: ambulance services, most dental exams and treatments, physiotherapy, occupational therapy, speech therapy, eye therapy, chiropractic services, and psychological services, acupuncture, glasses and contact lenses, hearing aids, and home nursing. It's a lot that it does not cover. So Medicare and the prescription pharmaceuticals. It's the Pharmaceutical Benefits Scheme, PBS. It's where Australians pay only part of the cost of most of the prescriptions that are bought at pharmacies. The rest is paid by PBS. So patients pay up to about $36, so general patients pay about $36, and then patients with the concession card pay only about $5. Non-PBS medicines are not subsidized by the Australian government, so pharmaceuticals provided in public hospitals are generally provided to public patients for free. The cost is covered by state and territory governments. The repatriation pharmaceutical benefit scheme is administered by the Department of Veterans Affairs, and it provides access to a range of pharmaceuticals and at a concessional rate for the treatment of eligible war veterans, war widows, widowers, and their dependents. And then you have the private health care system, and it's available to those who wish to fully or partly cover the cost of being admitted to the hospital as a private patient. Like I said before, you can have both Medicare and private if you want to pay for the private and have your medical, so you don't have to pay for the full private. Part of the cost is also covered by the Australian government through the MBS and the PBS. It's not compulsory, and you can opt out to buy private. You can opt out to buy private insurance, and you're able to mix and match the levels of coverage that you want with your private insurance, depending on what suits you and your medical needs. And it covers for some or all costs of range of other items not covered by Medicare. So you have the ambulance services, dental, prescription glasses, and physiotherapy. The nice thing about private is you actually get to choose your doctor. So unlike Medicare, you're able to go and decide who you want your doctor to be. There's reduced waiting time for elective surgery by having treatment in a private hospital, not in a public hospital. But you can be treated at a public hospital if you choose to. And it was shown that 40% have some form of private insurance in Australia, and 55% have some form of general treatment cover, even if they have Medicare. The governing of health services, so it's the responsibility of Australian Health Minister, the Commonwealth and the state territory ministers. They manage the managing is the responsibility of the relevant health minister and health department in each jurisdiction. Health ministers, referred to as the Standing Council on Health, they oversee reforms such as helping patients receive more seamless care across the sector of the health system. They improve the quality of care through higher performance standards and transparency improvement by local clinicians. And this is nice just to kind of see that they oversee the reforms that are important to make sure that the care for the patients is high, so the quality of care is higher, so they're really looking at their patients and trying to take care of their patients. These are a few more responsibilities that they have. I'm not going to read it over, but just for you to see. The regulation of health services, so like mentioned before, state and territory governments, they license or register private hospitals. Each state and territory has legislation relevant to the operation of the public hospitals. They're largely responsible for health-relevant industry regulations, such as for the sale and supply of alcohol and tobacco products. The Australian government's regulatory roles include overseeing safety and quality of pharmaceuticals and therapeutic goods and appliances. So whatever is given to their patients, they need to make sure that it's good, high quality. Managing international quarantine arrangements. Like I said in the first slide, Australia is a perfect place for quarantine. ensuring an adequate and safe supply of blood products, and then regulating the private health insurance industry. So the private health industry is actually regulated by the government. And then you just wanted to put in the registration of health professionals. It's under the National Registration and Accreditation Scheme. It was for health practitioners in July 1st of 2010. It was established to protect the public by ensuring that only suitably trained and qualified practitioners are registered. They facilitate the workforce mobility across Australia, and they enable the continuous development of a flexible, responsive, and sustainable Australian health workforce. And these are some of the healthcare workers that are registered or regulated under this scheme. Some other parts of the system, so health services are supported by other agencies, not just what we mentioned before. There's research and statistical bodies that provide information for disease prevention, detection, diagnosis, treatment, care, and associated policy. There's consumers and advocacy groups that contribute to public discussions and policy development. You have universities and hospitals that deal with the training of the healthcare professionals. And then you have voluntary and community organizations that raise money for research, running educational and health promotional programs, and they coordinate the voluntary care. So where does the money go? Funding for healthcare in Australia comes from a range of sources that include government, which are the state and territory governmental ministries. And then there's non-government sources, which is private health insurers, and then out-of-pocket. So this is the total expenditure on health by areas. So this is the hospital. The hospital takes up most of the health expenditure, as you can see here. The public and private hospitals, the public is more than private. And then you have primary health care. As you can see, medication takes up most of the primary health care expenditure. And then you have other reoccurrence. Again, medical services take more than research, aids and appliances, patient transfer services, and administration. Here you have another chart, and this chart just shows kind of the same thing, but who is paying for it exactly. So in the hospitals, it's mainly state and territory governments. But some is also on the Australian government, and then individuals pay a lot less than the government does. And then primary health care is mainly by the government, as you can see here. And then individuals pay a lot for their primary health compared to the hospitals. And then here's another chart just to show you a little bit more about who pays and what is under what. So here you have hospitals, which is 40%. And you have public hospital services and private hospital services. Now the public hospital services, like I said before, are funded by the Australian government, state and territory government fundings, and then private. Private is the same thing, but the most obviously is paid for is by private funding share. And then you have primary health care and the various things that go under. Most of these things are paid by all three, the Australian government, state, territory government, and private funding. The challenges to the system, so there's a few things that they're trying to work on. So there's a lot of changes going on, and some of the changes is the demography and disease patterns, the population ages, and the burden of disease grows. There's increased costs of medical advances, problems with health workforce supply and distribution, like we've mentioned a lot about them coming and going, staying in the country or leaving, getting education out and staying where they get their education, not coming back. Quality and safety of services. They want to invest more in health of the children in Australia. They need to balance the public and private sectors, the role of urban planning, and achieving equity in health requires more than providing just healthcare services. There's a lot more that they need to look into to provide equity. And we talked a little bit about the fact that Australia is such a big country, and most of the population is around, they're clustered into an area, but there's people that are still living, in rural Australia. And so I read that they were trying to work on having more of the medical students, try and incentivize them to actually go work out into the rural area so that they're not all being drawn into the clustered area where most of the population lives. So hopefully, they haven't really done much, but they're starting to, so hopefully that will help in the future. Yeah. Thank you.
you talked about quarantine, okay? And so let's just restate this. Why is it such a great place for quarantine?
Because it's a ginormous island surrounded by water, and there's no other countries that surround it.
So with the HIV story, it's interesting to me because I studied, as I was saying to Mesa, I studied the Australian healthcare system only for a couple of weeks. There has never been a significant outbreak of HIV in Australia. Just didn't happen there, okay? And there are, as far as I'm concerned, two reasons. One's the quarantine reason. In other words, they just didn't have people coming to them who were HIV positive. As the outbreak occurs in the rest of the world, they've got 1 to 2 years warning. So it's occurring in other places. It's not coming for whatever reason, because it's like nobody goes to Australia. People go to Australia, but I guess people with HIV were less likely to. I don't know. Okay. So they had time to understand this was coming, and then because they have such a sophisticated and successful healthcare system, they planned through various public health maneuvers to deal with the causes of HIV. So they worked with the sex worker population to encourage condom use and educate the sex workers about the risk of HIV. They started a needle exchange program, open, and again, I was there. We actually toured one of these places. You can come in as a drug. This was sort of the red light district in Sydney. You could come into a storefront, go into the back, help yourself to needles and syringes. Nobody asked who you were. Nobody told you what to do. You could go do your business and leave, recognizing that they weren't going to eliminate the substance abuse problem, but they could stop transmission of HIV. And they did it, very successful. So that there was never a significant HIV problem. I mean, there were some people with HIV in Australia, but very, very few, and it never got spread through the risk population. So it's an example of a quarantine story and a very successful healthcare system. Any other questions for Mesa? Thank you. Okay. Shall we?
Yeah, should I read my piece through, or?
We can do
Have a USB, it's where.
If you have it on your USB, then I can send it to everybody. Easily. It says, usually this is not a problem, so. Oops. So,
Protocol Global Health. There's a short video, maybe we'll watch it and we'll see how tired you are. So I know it's the end of the day, people are all tired, so I'm going to try to focus on the main topics here. When I was preparing the presentation, one of the things that caught me by surprise is how contradictory and conflicting some of the findings were. So on the one hand, it seemed as if the British people were extremely proud of their healthcare system in a kind of a nationalistic sense. So you had all these things like healthcare is great in Britain, and comparisons between Britain and the United States, how good it is in Britain, how poor it is in the United States. in how the expenditure on health in Britain is lower, but people live longer, etc. So on the one hand, the British were extremely proud of their healthcare systems. On the other hand, you had cartoons like this, which started out with the National Health Service in Britain, but ended up somewhere else. So it was kind of contradictory. So you had really strong sides of NHS and then some poor sides. So a bit about the country. And when we talk about Britain, we're talking about 4 countries. We're talking about England, Wales, Scotland, and Northern Ireland. So 2 minutes of history, literally 120 seconds. Smaller than Mesa's country, but surrounded by water. And people divide Britain's history into 2 parts. Either people invade Britain or Britain invades other countries. So you can kind of look at Britain's history according to those 2. So about 12,000 years ago, Stone Age, people start settling in what's known as Britain today. And you still have Stonehenge as kind of a strange symbol of that era. You have the Celts coming in from mainland Europe, basically kind of hired help, mercenaries, but eventually they take over the country, tens to hundreds of tribes. And then you have the Romans coming in from the Roman Empire, and they establish a lot of the foundations of Britain. So it's the roads and the paths and the Christianity, and the Celts become Christian. And then you have the Anglo-Saxon coming in from the area of Germany, Denmark, Northern Europe. So we tend to look at the last 500 years, but a lot starts in the Middle Ages when Normans come in from Normandy, and you have cathedrals built in cities, and you have what's called the manor system, which is a bit what Professor Schuster was talking about a couple of days ago, in which it's not exactly serfs, but you have a lord, and you have a lot of people working his lands and paying taxes. That has a lot to do with how the healthcare system was established. And this kind of goes on. One of the areas that's worth mentioning is the 16th century, Francis Drake, second person to circumnavigate the world, and that brings about conquering and eventually the British Empire, which at its best or at its worst, depends who you are and what your narrative is, covers all the red areas here. So you have Southern Africa, which includes Rhodesia and South Africa, former Rhodesia, Zimbabwe, Canada, Australia, New Zealand, India, but we're talking about the Indian subcontinent, so it includes Pakistan and modern-day Bangladesh, and obviously the United Kingdom. So back to where we are today, and this is Britain today. As opposed to the British Empire, currently is the 78th largest country in the world in terms of size, so it really went through significant downsizing in the 20th century. GDP per capita is about $42,000, so it's 25th in the world. Population about 65 million. These are the religious, the ethnic groups, and now about the national healthcare system. I chose to focus on a bit of the history, just to emphasize the challenges that the NHS has been going through. So established in 1948, and the general idea was to provide comprehensive, universal, and free at the point of delivery healthcare. So it's supposed to be for everyone, and it's supposed to literally be free. Not reimbursement, not deductibles, but literally you go, you get service, you don't pay at all. And it's all supposed to be under one roof. So you have GPs, hospitals, community services, nurses, etc. And it's supposed to be funded primarily through taxes. So the original structure was that the family physician, and in a sense this is still the system, is the gatekeeper. So you go to the family physician wants to refer you onwards to a hospital, to a specialist, he or she does so, etc. But you have community health services and other health services. In the 1980s, British government starts recognizing that there's just not enough money to go around. That it seems reasonable, but eventually that healthcare expenses are too large. And Margaret Thatcher's government decides on something that I think I understood, but I'd be happy to hear if not, something called the GP fund holders, which means that as opposed to a GP providing services and getting paid by the government, Thatcher's government decides to give GPs kind of a lump sum if they are under the GP fund holders agreement, saying, well, you conduct your business now, and if you send people to do too many exams and to hospital too much and to do too much interventions,